All right, this is the Mental Health ATI Chapter 13, Depressive Disorders. Depression is a mood affective disorder that is a widespread issue ranking high among causes of disability. A client who has depression has a potential risk for suicide, especially if they have a family or personal history of suicide attempts, comorbid anxiety disorder, or panic attacks. Comorbid substance use disorder or psychosis, poor self-esteem, a lack of social support, or a chronic medical condition. Common comorbidities, anxiety disorders. These disorders are comorbid in approximately 70% of clients who have a depressive disorder. This combination makes a client's prognosis poorer with a higher risk for suicide and disability. Psychotic disorders like schizophrenia. Substance use disorders. Clients often use substances in an attempt to relieve manifestations of depression or self-treat mental health disorders. Eating disorders and personality disorders. Depressive disorders recognized by the DSM-5-TR. Major depressive disorder, which is MDD. A single episode, or recurrent episodes of unipolar depression not associated with mood swings from major depression or to mania, resulting in a significant change in a client's normal functioning, social, occupational self-care, accompanied by at least 5 of the following specific clinical findings, which must occur almost every day for a minimum of 2 weeks and last most of the day. Depressed mood, difficulty sleeping or excessive sleeping, indecisiveness, decreased ability to concentrate, suicidal ideation, increase or decrease in the motor activity, inability to feel pleasure, increase or decrease in weight of more than 5% of total body weight over 1 month. A bereavement exclusion was previously used when a client experienced clinical findings of depression within the first 2 months after a significant loss. Now, however, a client can be diagnosed with depression during this time, so that needed treatment will not be delayed. MDD can be further diagnosed in the DSM-5-TR with a more specific classification, specifier, including the following. Psychotic features. This presence of auditory hallucinations, such as voices telling the client they are sinful, or a presence of delusions, such as the client thinking that they have a fatal disease. Or postpartum onset, a depressive episode that begins within 4 weeks of childbirth, known as postpartum depression, and can include delusions, which can put a newborn infant at high risk of being harmed by the mother. Seasonal affective disorder, or SAD, a form of depression that occurs occasionally, usually during the winter when there is less daylight. Light therapy is the first line of treatment for SAD. Persistent depressive disorder, a milder form of depression that is usually has an early onset in childhood or adolescence and lasts at least 2 years for adults, 1 year for children. Persistent depressive disorder contains at least 3 clinical findings of depression and can, later in life, become a major depressive disorder. Premenstrual dysphoric disorder, or PMDD, a depressive disorder associated with the luteal phase of the menstrual cycle. The prevalence of premenstrual dysphoric disorder is 2% to 6% of menstruating clients and causes problems that can be severe enough to interfere with the ability of a client to work or interact with others. Emotional manifestations can include mood swings, irritability, depression, anxiety, feeling overwhelmed, and difficulty concentrating. Physical manifestations can include lack of energy, overeating, hyper or insomnia, breast tenderness, aching, bloating, and weight gain. Treatment includes exercise, diet, and relaxation therapy. Substance-induced depressive disorder, clinical findings of depression that are associated with the use of or withdrawal from drugs and alcohol. Client care. Care of a client who has MDD will mirror the phase of the disease that the client is experiencing. Acute phase. Treatment is generally 6 to 12 weeks in duration. Potential need for hospitalization. Reduction of depressive manifestations is the goal of treatment. Assesses suicide risk and implements safety precautions or one-to-one observation as needed. Continuation phase. Treatment is generally 4 to 9 months in duration. Relapse prevention through education, medication therapy, and psychotherapy is the goal of treatment. Maintenance phase. This phase can last for years. Prevention of future depressive episodes is the goal of treatment. Assessment. Risk factors. Family history and the previous personal history of depression are the most significant risk factors. Depressive disorders are twice as common in females than in males. Depression is very common among clients over 65, but this disorder is more difficult to recognize in the older adult client and can go untreated. It is important to differentiate between early dementia and depression. Some clinical findings of depression that can look like dementia are memory loss, confusion, and behavioral problems. Social isolation or agitation. Clients can seek health care for somatic problems that are manifestations of untreated depression. Neurotransmitter deficiencies. A serotonin deficiency affects mood, sexual behavior, sleep cycles, hunger, and pain perception, or a norepinephrine deficiency affects attention and behavior. Can be risk factors for depression. Imbalances of the neurotransmitters norepinephrine, dopamine, acetylcholine, GABA, and possibly glutamate can play a role in the occurrence of depression. Other risk factors: stressful life events, presence of a medical illness, a client's postpartum period, comorbid anxiety or personality disorder, comorbid substance use disorder, and trauma occurring early in life. Depressive disorders occur throughout all groups of people. Depression can be the primary disorder or a response to another physical or mental health disorder. Expected findings: anergia, which is lack of energy; anhedonia, which is lack of pleasure and normal activities; anxiety, reports of sluggishness, most common, or feeling unable to relax and sit still; vegetative findings, which include a change in eating patterns, usually anorexia and MDD, increased intake and persistent depressive disorder, and PMDD; change in bowel habits, usually constipation; sleep disturbances, and decreased interest in sexual activity. Somatic reports is fatigue, gastrointestinal changes, and pain. Physical assessment findings: the client most often looks sad with blunted affect. The client exhibits poor grooming and lack of hygiene. Psychomotor retardation, slowed physical movement, slumped posture is more common, but psychomotor agitation, restlessness, pacing, finger tapping can also occur. The client becomes socially isolated, showing little or no effort to interact. Slowed speech, decreased verbalization, delayed response. The client might seem too tired to speak and can sigh often. Standardized screening tools: Hamilton Depression Rating Scale, Beck Depression Inventory, Geriatric Depression Scale, short form, Zung Self-Rating Depression Scale, and the Patient Health Questionnaire, PHQ-9. Patient-centered care, Milieu therapy, suicide risk. Assess the client's risk for suicide and implement appropriate safety precautions. Self-care, monitor the client's ability to perform activities of daily living and encourage independence as much as possible. Communication, relate therapeutically to the client who is unable and unwilling to communicate. Make time to be with the client even if they do not speak. Make observations rather than asking direct questions, which can cause anxiety to the client. For example, the nurse might say, "I noticed that you attended the unit group meeting today," rather than asking, "Did you enjoy the group meeting?" These directions and simple concrete sentences, because a client who has depression can have difficulty focusing on and comprehending long sentences. Give the client sufficient time to respond when holding a conversation due to the possible delayed response time. Maintenance of a safe environment. Counseling. This can include individual counseling to assist with the following: problem solving, increasing coping abilities, changing negative thinking to positive, increasing self-esteem, assertiveness training, using available community resources. Psychopharmacological therapies. Client teaching for all antidepressants. Do not discontinue medication suddenly. Therapeutic effects are not immediate, and it can take several weeks or more to reach full therapeutic benefits. Avoid hazardous activities like driving or operating heavy machinery due to the potential adverse effect of sedation. Notify the provider of any thoughts of suicide. Avoid alcohol while taking an antidepressant. Amitriptyline. This is a tricyclic antidepressant. Client education. Change position slowly to minimize dizziness from orthostatic hypotension. To minimize anticholinergic effects, choose sugarless gum, eat foods high in fiber, and increase fluid intake to 2 to 3 liters a day from food and beverage sources. Monoamine oxidase inhibitors, MAOI, phenolzine, client education. Due to the risk for hypertensive crisis, avoid foods with meats, liver, dried or cured fish, and protein dietary supplements. Due to the risk of medication interactions, avoid all medications, including over-the-counter, without first discussing them with their provider. Atypical antidepressants, bupropion, client education. Observe for headache, dry mouth, GI distress, constipation, increased heart rate, nausea, restlessness, or insomnia, and notify the provider if they become intolerable. Monitor food intake and weight due to appetite suppression. Avoid administering if at risk for seizures. Selective serotonin reuptake inhibitors, leading treatment for depression. Select prototype medication is paroxetine. Other medications, citalopram, fluoxetine, and sertraline. Client education. Adverse effects can include nausea, headache, and central nervous system stimulation, agitation, insomnia, and anxiety. Be aware that sexual dysfunction can occur and notify provider if effects are intolerable. Observe for manifestations of serotonin syndrome. If any occur, withhold the medication and notify the provider. Avoid the concurrent use of St. John's wort, which can increase the risk of serotonin syndrome. Follow a healthy diet and exercise regime because weight gain can occur with long-term use. Expected pharmacological action. SSRIs selectively inhibit serotonin reuptake, allowing more serotonin to stay at the junction of the neurons. SSRIs do not block uptake of dopamine or norepinephrine. Paroxetine causes CNS stimulation, which can cause insomnia. As SSRIs have long effective half-lives, up to 4 weeks are necessary to produce therapeutic medication levels. Therapeutic uses. SSRI antidepressants are the first-line treatment for panic disorders and trauma and stressor-related disorders. Paroxetine, generalized anxiety disorder, panic disorder, decreases both the frequency and intensity of panic attacks and also prevents anticipatory anxiety about attacks. Obsessive compulsive disorder, reduces manifestation by increasing serotonin. Social anxiety disorder, post-traumatic stress disorder, depressive disorder, adjustment disorder, associated manifestations of dissociative disorders. Sertraline is indicated for panic disorder, OCD, social anxiety disorder, and PTSD. Citalopram is indicated for panic disorder, OCD, GAD, PTSD, and social anxiety disorder. Citalopram is indicated for GAD, OCD, panic disorder, PTSD, and social anxiety disorder. Fluoxetine is used for panic disorder, social anxiety disorder, OCD, and PTSD. Fluvoxamine is used for OCD, GAD, social anxiety disorder, and PTSD. Early adverse effects. First few days, weeks is nausea, diaphoresis, fatigue, and drowsiness. Client education. Report adverse effects to the provider. Take the medication as prescribed. These effects should soon subside. Avoid driving if these effects occur. Later adverse effects. Up to 5 to 6 weeks of therapy. Sexual dysfunction, impotence, delayed or absent orgasm, delayed or absent ejaculation, decreased sexual interest, and weight gain and headache. Client education. Report problems with sexual function. Manage with dose reduction, medication holiday, changing medications. Weight changes. Occurrence in weight loss early in therapy that can be followed by weight gain with long-term treatment. Nursing actions. Monitor the client's weight. Client education. Follow a well-balanced diet and exercise regularly. Gastrointestinal bleeding. Nursing actions. Use cautiously in clients who have a history of gastrointestinal bleed, ulcers, and those taking other medications that affect blood coagulation. Client education. Report indications of bleeding, dark stools, emesis that has an appearance of coffee grounds. Hyponatremia. More likely in older adult clients taking diuretics. Nursing actions. Obtain baseline blood sodium and monitor levels periodically throughout treatment. Serotonin syndrome can begin 2 to 72 hours after starting treatment and can be lethal. Manifestations: confusion, agitation, poor concentration, hostility, disorientation, hallucinations, delirium, seizures leading to status epilepticus, tachycardia leading to cardiovascular shock, libel blood pressure, diaphoresis, nausea, vomiting, diarrhea, coma leading to apnea, and death in severe cases. Observe for manifestations. If any occur, withhold the medication and notify the provider. Bruism, grinding and clenching of teeth usually during sleep. Nursing actions. Report bruism to the provider who may switch the client to another class of medications, treat bruism with low-dose buspirone. Client education. Use a mouth guard during sleep. Withdrawal syndrome. Nausea, sensory disturbances, anxiety, tremor, malaise, and unease. Client education. After a long period of use, taper the medication slowly according to a prescribed tapered dosing schedule to avoid withdrawal effects. Avoid abrupt discontinuation of the medication. Contraindications and precautions. Paroxetine is a teratogenic medication. Other SSRIs pose less risk during pregnancy. SSRIs are contraindicated in clients taking MAOIs or TCAs. Clients should avoid alcohol while taking SSRIs. Use cautiously in clients who have liver and renal dysfunction, seizure disorders, or a history of gastrointestinal bleeding. Use SSRIs cautiously in clients who have bipolar disorder due to the risk of mania. Interactions. Concurrent use of TCAs, MAOIs, or St. John's wort can cause serotonin syndrome. Nursing actions. Discontinue MAOIs 14 days prior to starting an SSRI. Fluoxetine should be discontinued 5 weeks before starting an MAOI. Advise the client against concurrent use of TCAs or St. John's wort with SSRIs. Concurrent use with warfarin can displace warfarin from bound protein and result in increased warfarin levels. Nursing actions. Monitor prothrombin time, which is PT, and INR levels. Assess for indications of bleeding and the need for dosage adjustment. Concurrent use with TCAs and lithium can result in increased level of these medications. Client education. Avoid concurrent use. Concurrent use with NSAIDs and anticoagulants can further suppress platelet aggregation, thereby increasing the risk of bleeding. Monitor for indications of bleeding, like bruising and hematuria, and notify the provider if they occur. Nursing administration. SSRIs may be taken with food. Sleep disturbances are minimized by taking the medication in the morning. Take the medication on a daily basis to establish therapeutic plasma levels. It can take up to 4 weeks to achieve therapeutic effects. Serotonin norepinephrine reuptake inhibitors, venlafaxine and duloxetine. Nursing actions. Adverse effects include nausea, insomnia, weight gain, diaphoresis, and sexual dysfunction. Caution in administering to clients who have a history of hypertension. Purpose. Expected pharmacological action. Inhibit the uptake of serotonin and norepinephrine, minimal inhibition of dopamine. Therapeutic uses. Used for major depression, panic disorders, and generalized anxiety disorder. Complications. Headache, nausea, agitation, anxiety, dry mouth, and sleep disturbances. Report adverse effects to the provider. Hyponatremia, especially in older adult clients taking diuretics. Obtain baseline blood sodium and monitor level periodically throughout treatment. Anorexia resulting in weight loss. Monitor the client's weight. Follow a well-balanced diet and exercise regularly. Hypertension. Monitor for increases in blood pressure. Sexual dysfunction. Report problems with sexual function. Manage with dose reduction, medication holiday, and changing medications. Contraindications or precautions. SNRIs are teratogenic. SNRIs are contraindicated in clients taking MAOIs. Duloxetine should not be used in clients who have hepatic disease or in those who consume large amounts of alcohol. Avoid abrupt cessation in the medication. Avoid alcohol while taking SNRIs. Interactions. Concurrent use of MAOIs and St. John's wort can cause serotonin syndrome. Nursing action. Discontinue MAOIs 14 days prior to starting an SNRI. Avoid concurrent use of St. John's wort along with SNRIs. CNS depression with alcohol, opioids, antihistamines, and sedative hypnotics. Avoid concurrent use. Concurrent use with NSAIDs and anticoagulants can further suppress platelet aggregation, thereby increasing the risk of bleeding. Monitor for indications of bleeding, bruising, and hematuria, and notify the provider if they occur. Duloxetine should not be used in clients who have hepatic disease or in those who consume large amounts of alcohol. Avoid abrupt cessation of the medication. SNRIs may be taken with food. Take the medication on a daily basis to establish therapeutic plasma levels. Medication can take up to 4 weeks to achieve therapeutic effects. Alternative or complementary therapies. St. John's wort. It's a plant product, Hypericum perforatorum, not regulated by the U.S. Food and Drug Administration, is taken by some individuals to relieve manifestations of mild depression. The nursing actions. Adverse effects include photosensitivity, skin rash, rapid heart rate, gastrointestinal distress, and abdominal pain. St. John's wort can increase or reduce levels of some medications if taken concurrently. The client should inform the provider if taking St. John's wort. Medication interactions is potentially fatal serotonin syndrome can result if St. John's wort is taken with SSRIs or other types of antidepressants. Food containing tyramine should be avoided. Light therapy. First-line treatment for SAD. Light therapy inhibits nocturnal secretion of melatonin. Exposure of the face to 10,000 lux light box 30 minutes a day, once or in 2 divided doses. Therapeutic procedures. Electroconvulsive therapy can be useful for some clients who have a depressive disorder and are responsive to other treatments. A specially trained nurse is responsible for monitoring the client before and after this therapy. Transcranial magnetic stimulation uses electromagnetic stimulation, MRI strength magnetic pulsation, to stimulate focal areas of cerebral cortex. It is indicated for depressive disorders that are resistant to other forms of treatment. Vagus nerve stimulation uses an implanted device that stimulates the vagus nerve. It can be used for clients who have depression that is resistant to antidepressant medications. Deep brain stimulation, a treatment that surgically implants electrodes into the brain to stimulate underactive regions. It is reserved for clients who have tried many other treatments that have failed. The nurse should use standard post-operative care for these clients. Interprofessional care. Psychotherapy by a trained therapist can include individual cognitive therapy, or CBT, interpersonal therapy, or IPT, group therapy, and family therapy. CBT assists the client to identify and change negative behavior and thought patterns. IPT encourages the client to focus on personal relationships that contribute to the depressive disorder. Client education. Continuation phase followed by maintenance phase. Review manifestations of depression with the client and family members in order to identify relapse. Reinforce intended effects and potential adverse effects of medication. Explain the benefits of adherence to therapy. 30 minutes of exercise daily for 3 to 5 days each week improves clinical findings of depression and can help to prevent relapse. Even shorter intervals of exercise are helpful. Exercise should be regarded as an adjunct to the other therapies for the client who has major depressive disorder. Nursing evaluation of medication effectiveness. Depending on therapeutic intent, effectiveness is evidenced by the following: verbalized feeling of less anxiety, description of improved mood, improved memory retrieval, maintenance of a normal sleep pattern, greater ability to participate in social and occupational interactions, improved ability to cope with manifestations and identified stressors, ability to perform activities of daily living, and report of increased well-being. Okay, so here's some questions. A charge nurse is discussing the care of a client who has major depressive disorder with a newly licensed nurse. Which of the following statements by the newly licensed nurse indicates an understanding of the teaching? The client is the greatest risk for suicide during the first weeks of an MDD episode. A nurse is caring for a client who has major depressive disorder. Which of the following should the nurse identify as a risk factor for depression? History of chronic bronchitis, recent death in the family history of depression, and personal history of panic disorder. A nurse is interviewing a client who has a new diagnosis of persistent depressive disorder. Which of the following findings should the nurse expect? Presence of manifestations for at least 2 years. A nurse is working on an acute mental health unit is admitting a client who has major depressive disorder and comorbid anxiety disorder. Which of the following actions is the nurse's priority? Placing the client in one-on-one observation.